Hi everybody and welcome to this ear, nose and throat service training that Community Pharmacy West Yorkshire are putting on to help you understand the service, how it works, and go into any questions and answers you have about the service specification. Before I start the presentation, I'll just introduce you to a couple of really key people. So the first one is Sobia. Sobia works for Leeds ICB, and she has been instrumental in getting this service developed and getting it in. So welcome, Sobia. And I'd also like to welcome Lisa from Community Pharmacy West Yorkshire. Lisa has led on developing this service, has put a huge amount of effort and time, thought and energy into getting this service to where it is. So I'd like to say a big thank you to Lisa, because without her, we wouldn't all be sat here talking about the service. So thank you, Lisa, you really have done a great job. So without much more ado, I am going to now share the screen and start the presentation. Can somebody confirm they can see that for me, please? They can, nodding heads, that's fine. So we've done the instructions. You know we're recording the event for those that are actually on as well. So I thought I'd start with a bit of an outline as to the journey we took to get to the Leeds Ear, Nose and Throat Service. I think it's helpful to understand. So we know from information we get from GP practices that one of the most common CPCS reasons for referral back is ear, nose and throat symptoms. You know, patients often get, GPs often get referrals back which state things like the patient has earache, not eligible for CPCS, which is not true. Earache needs antibiotics, which is also not true a lot of the time, and earache not able to undertake exam. Now, whilst we have now can do examinations as part of this service, it is important to note that actually earache can be managed within community pharmacy, often without an examination, just by questioning the person about their symptoms. But we know there is times when actually an examination will help that differential diagnosis. Other areas in England commission a PGD service for low acuity conditions, including in a couple of areas for ear, nose and throat. And the evidence from this is that this really helps manage more patients with low acuity conditions and do so safely. NHS did let us know there was some money available to increase access to primary care. And so Community Pharmacy West Yorkshire decided to put a bid forward. Now, at the time, nationally, NHS England had put a hold on any antibiotic PGD community pharmacy services because our preference would be for a PGD service. But at the time, that wouldn't have been agreed and approved. So we actually went with an ENT service. And the idea is that it's to extend CPCS and enable you to deal with more patients within community pharmacy. By not having a PGD element to it, just having the assessment, it meant that actually it could be then approved and then funding could be allocated to the service, which is indeed what's happened. There is only limited funding though, so the service is only targeted on specific primary care networks based on deprivation, and they're geographically needed to make sense to patients too. And it's been refunded from non-recurrent one-off NHS funds. And as we said in the invite letter, at this point in time, Leeds ICB has not secured recurrent funding for this service, so it could end when the money goes. Now, we suspect we've got enough for 12 months, and then that 12 months we will be collating data, and we'll be using that then to build that case for onward commissioning of the service, so it becomes a regular service rather than just a short-term service. It's not ideal, but it felt, you know, we were in the position it felt we wanted to make that investment and increase the skills. That's partly why we need the service to be a success. We need the evidence so we can use it in Leeds, but we also need the evidence so we can use it across the whole of West Yorkshire, so it can support the addition of PGDs, and we can hopefully get the service bedded in as a routine and regular offer across the whole of West Yorkshire, and that certainly is our aim in Community Pharmacy West Yorkshire. So the service, what does it aim to achieve? So we want to ensure patients have access to an ear, nose and throat examination in community pharmacy. We want to help improve the access to advice and through community pharmacy, enable us to slightly increase the acuity of patients that we can deal with, because with that examination, it will enable us to support more patients without referring back to the GP. We also know that keeping people within community pharmacy does actually reduce requests for inappropriate antibiotics, so it helps the whole antimicrobial resistance. Really important we promote the role of the pharmacist and the pharmacy team in self-care and the clinical skills that we have. And so it's not intended to replace the CPCS service, but this is intended just to enhance it and give us an alternative option where that's appropriate. As I said, it's going to manage the ENT conditions that often lead to GP practice attendance. And really, this is to help ensure that you can give that assurance back to patients that actually quite a lot of the time an antibiotic probably isn't needed. You can give them that self-care management, that how to look after that pain. You can give them the red flags that when they would need to do something different. So yeah, the whole idea of this is just to empower you to help your patients more. What's really key in the service is that patients followed up 3 to 5 days after initial assessment. That's for a couple of reasons. The main reason is about safety netting, to make sure that we haven't missed something or that things haven't got worse, but also it's to record the outcomes of the service so we can see, did this service have a positive impact on the patient care or not. So the great flow chart here, and I'm going to talk you through the different ways that patients can access a service, the different outcomes in the service, and how to escalate if needed. I'll go into some more detail in the later slides about some of the key points like the red flags, but I think it's really helpful to go through this patient flow. So I'm going to start with the green box at the top around walk-in. So the service has been designed for a walk-in element. So that means if you have somebody walking in with ear, nose and throat symptoms into the pharmacy and the patient's eligible, and we'll go through your eligibility in a minute, and you feel that ear, nose and throat examination is required to aid the diagnosis, you can actually then refer them into the ear, nose and throat service. The eligibility is also on this, so it's around, they've got to be present to the pharmacy, must be with a parent if they're or a guardian if they're under 16, over a year old, which is in line with CPCS. They must give consent to share the details with GP, and they must agree to that follow-up conversation. So if they don't give consent or if they're under a year, we can't include them. There is some more eligibility criteria which are based on symptoms, but I'll go through that in a later slide. The other mechanism that we can trigger the ear, nose and throat service is if we get a CPCS referral. So if you start doing a CPCS consultation, either remotely or face-to-face, and you feel that an ear, nose and throat examination is required to aid diagnosis, so it might not be, and reasons why it might not be required is that the earache hasn't been there for 3 days. We know that if an earache is less than 3 days, it just should be usual self-management, so that wouldn't and shouldn't trigger usually an ear, nose and throat assessment service. Again, check the eligibility, which I'll go through in a bit more detail, and you can refer them into the ear, nose and throat assessment service. Now, if you follow the blue kind of boxes for the CPCS referral element, it's really important that you do still record the CPCS on PharmOutcomes or whichever platform you now use, which might not be PharmOutcomes for some of you. And the reason it's important that you record that is then it closes that off. So it'll show the GP that you've managed that patient and then you referred them onto ear, nose and throat. So when you close it, you must, under the consultation outcome, select reason not listed and then record it as referred to CPENT Assessment Service. So it's really clear from the CPCS audit trail that the patient was referred in through CPCS, but you actually have closed it because you're managing them through a different route. That will be the end of CPCS. You will still get your CPCS payment, but that will end the CPCS, but you'll have gathered quite a lot of information you need for the ear, nose and throat service as part of that initial consultation. So whether you've come in through walk-in or the CPCS referral route, then you've got the ENT assessment service will then start. It needs to be a pharmacist. The main reason for that is VAT, and we know there's a national discussion going on around VAT for other pharmacy professionals, notably pharmacy techs, but currently it has to be the pharmacist. And it has to be a pharmacist who's undertaken all the appropriate training, and I'll cover that later. So the patient examines, the pharmacist examines the patient in the consultation room and gives appropriate advice around self-care. So we then have several different options for what happens as an outcome. So I'll start from the bottom. So red flags. If you see a red flag, so for example, a child or indeed an adult is blue around the lips, they have irregular breathing, they have any signs of sepsis, they have got signs of epiglottitis, you know, you need to escalate that really quickly. So you've got to decide what the most appropriate thing is. For epiglottitis, it would be a 999 call. But for some, it could be a GP, but an urgent appointment. So if that's the case, you will need to make that red flag escalation appropriate to that red flag. And whether if it's in hours, it may be the GP, but I say if it's out of hours, it might also be the GP out of hour service. And that it's exactly the same referral process as we see for CPCS. So this should be exactly what we do with CPCS anyway. So it's not new. It's just actually we've just duplicated the CPCS referral process. Sorry, I just can't see some of my screen. Let me just change that. There we go. If you do an examination and you think there's a bacterial infection or another reason to refer to the GP for assessment, either further assessment or for prescription only medicine, then you need to refer to the GP, and the pharmacy will need to arrange that appointment. So really important, you don't just say to the patient, oh, you need to go to the GP. You do need to actually be really clear that you phone up the practice and arrange an appointment within an appropriate time frame for that patient. If you think that it isn't infected or bacterial, certainly, and the patient requires over-the-counter medicine, you give that advice, and you either offer a purchase over the counter, which is what most patients should be encouraged to do. However, if you feel that paying for the medication is an issue and you have access to either the pharmacy first or the minor ailment service, you are able to access that to provide free medication if that's appropriate for that individual. But as with CPCS, we know that actually, not all supplies, in fact, more CPCS consultations end in just advice rather than providing a medicine. That might be the case. And if that's the case, you just give that self-care advice. Really important that we include the antimicrobial stewardship messages, and I'll talk about that a bit later. And also, as with CPCS, exceedingly important that we always advise the patient that if their symptoms don't improve or get worse, they need to come back to see you at the community pharmacy or to see their GP. And that's why as part of this, we recommend that you give patients a target leaflet. I'll go through those later, but they are really clear as to when patients should themselves recognise they need to come back to either the GP or indeed 111. So it's really important we do that safety netting. And I'm sure those of you that attended, well, you all will have attended the training. The trainer who for all three sessions was Dr. Phil was really clear about how important it was to get that referral right if it's needed, and that messaging right around safety netting. Across the bottom, you'll see that the reminder that we've got to follow up all patients in 3 to 5 days. If you don't follow patients up, you will not get the full payment for this service. So really important that that happens as part of the process. So hopefully that's kind of gone through the patient flow, and this flow chart is available to you all, so it might be really helpful to print it out and have it in your pharmacy, particularly in the early days. On the back page of the flow chart, you'll find patient eligibility. Again, really helpful to have that printed out and have it handy. So eligibility for patients. So inclusion criteria is earache for longer than 3 days, discharge from the ear, blocked ear, hearing loss, and there's some kind of elements to that you can read for yourself, nasal blockage, sore throat, and one of the other symptoms of that, might be that it's been going for more than 7 days, or they're very worried, or they've got a very high temperature and feel hot and shivery. There is at the end, you'll see that any ear, nose and throat type condition, the pharmacist can accept them onto the service. There's that kind of catch-all, but we do expect that will be quite rare. But what we don't want to do is say you can't do it. If you really think there's a clinical reason for making that assessment, you can. But we will expect for some patients, they come into CPCS, for example, with earache or walk into the pharmacy, we don't expect they will all get an ENT examination. I think we've gone through the kind of consent issue in the previous slide, and again, just that note around, many ENT symptoms can be managed without an examination. So this is about when you feel it's needed to aid that diagnosis or to give assurance to that individual. So accreditation. So pharmacist training requirements. There's several of these. We don't encourage adding things that aren't needed, but because this is something different, wielding an otoscope isn't something which most of us have been trained for throughout our clinical training. Really important, you've got to, every pharmacist must have done these things. So gone to the CPPE ENT, clinical assessment skills workshop. Now that's a bespoke workshop. If anybody's missed that, there is no other CPP training they can access themselves. We are going to work with CPP to put another event on probably in September, but if somebody's missed it, you know, they can't just start doing the service without completing that. Attendants are watching this online training. Really important people understand how the service works. You must complete the minor ailment declaration of competence to declare you are competent to deal with the minor ailments. And that gives the assurance that you have kind of reflected, because, you know, there might be additional training you need to do over and above what we've listed here. And that will vary for each pharmacist. So it's about the pharmacist making that assessment on the competencies they need and what they need to refresh themselves on. We must have done the HE Antimicrobial Stewardship learning and e-assessment. Many of you might have done that already through the work with the PQS, but if you haven't, that's essential that we're all up to date on the antimicrobial stewardship messages. And as always, read, and I would say reread the service specification, because when you read something once, you're taking so much, and actually once you've done one or two, you'll find that actually going back to it and just refreshing yourself of how the service should be done is really important. And what is also really important is the nice clinical knowledge skills you should have them all for CPCS anyway, but you will need to go through this for the ear, nose and throat condition, just so you're up to date. And as I must reiterate, only pharmacists who completed all the above training can provide the service. This is not something which somebody can do just because they think they know what they're doing. We have to make sure that we've got that level of accreditation completed. So the consultation, and this is just key points. Again, there'll be more in the service spec for you, but some of the key points. So it's got to be done face-to-face, and it's got to be done in the consultation room. You'll need to cover patient assessment and physical examination using a structured approach. Ensure that you review the patient summary care record if that's needed with a suitable consent. So it's around you making that, you know, consent call, whether you need to get that consent for the patient or it's in their best interest. And we've talked about red flags already. Need to give advice. We need to make sure we assure people about what we've discovered, what that means and how they can look after themselves. And that needs to include antimicrobial stewardship advice. So it needs to have a very clear message around infections not being bacterial and antibiotics, you know, only being used when needed. We've spoken about supplying with over-the-counter product in the flowchart, so I won't go through that. And the other thing is, you know, we also spoke about this in the flowchart, but worth reiterating, I think, that if you think they need antibiotics because it looks to you to be bacterial, or indeed you think they need some other prescription-only medicine treatment, you've got to make that referral back to the patient's GP practice. But please don't say, oh, you need antibiotics, we'll send you to the doctors, because that gives that expectation that they're going to get antibiotics when they get to the practice. And that might not be the case. A practice might actually make a different assessment. So as much as we don't like it when the GP practices give patients an expectation of what we're going to do, I think we need to make sure we don't do the same. And again, remember that safety netting. We've got that statement we use for CPCS. We must use it at the end of every ENT consultation because it helps protect you as the health professional to ensure that you have given patients the right advice, because with the best will in the world, somebody might look actually relatively well, but things can get worse and they need to know what to do if that is the case. So antimicrobial stewardship. We've talked about the requirement to discuss antimicrobial stewardship and antibiotics not being needed for every consultation. And I would recommend you provide patients with a target leaflet which you can print off. You can see both sides. We've put a snapshot of those in the slides for you. They're recommended because they provide really good self-care advice. They talk about how long symptoms can last. So it's really helpful for patients to understand that sore throats can last quite a while, and that's normal. And also safety netting and when to reconsult. So it really helps, again, protect you. It gives a really good aid memoir actually to go through your consultation, because you tick which condition they've got, and then it gives you that prompt to go through all the key points with them, and then they can go away with that. So they've got that to refer back to. And yeah, discuss those supportive measures that are going to relieve symptoms too. So, you know, it's about them understanding what they can do to make themselves feel better. And some of the key messages, and I've actually taken these screenshots about from the West Yorkshire Healthy Together website, which I'm going to attempt to show you. So we'll try that in a minute, but we know this is from the ear, nose, and the earache page, and it's for children. This website I'm going to take you to is for children and young adults. Excuse me. It's really clear about those messages that antibiotics don't usually speed up recovery. Earache generally improves in otherwise healthy vaccinated children. And actually, if we look at antibiotics versus no antibiotics, which is the purpley pink section at the bottom, we know that 8 out of 10 children with middle ear infection or earache who don't take antibiotics feel better within 2 to 3 days. And if we give all those 10 children antibiotics, only 1 more child actually feels better. And if we go to the green section that's on the right-hand side, antibiotics cause harm. So 3 out of 10 of those people that take antibiotics are likely to have, vomiting, diarrhea, headache, nausea. So, we need to really balance using antibiotics when they're needed. And absolutely, we need to make sure they're used when they're needed. But it's about balancing the fact that actually you're going to have more harm or more good from antibiotic. So I'm going to stop sharing now and attempt to reshare with you, but reshare the Healthier Together website. So. Can somebody just verbally confirm that they can see that website for me, please?
Ruth, it's in a different language?
Yes, I realise. There we go. So that was me playing earlier.
Healthier Together, improving the health of children.
So this is the Healthier Together website. It's for children and young people. It's been developed with input from across the range of health professionals in West Yorkshire, including pharmacists, community pharmacists, and it's
choose a topic.
Sorry, I've got recite on. So you can choose a topic. So actually, there's loads of things on there. It's got health advice for you. It's got general advice about what's normal in the baby, but it also has ear, nose, and throat specific advice. So if we look at the
professionals,
I'm just going to turn off accessibility tools.
Accessibility tools.
Sorry, I should have reset this and didn't. So you can see here it's got a huge amount of information about earaches when I click through to it.
Link.
I don't think I can turn her off now, I've got her on. And it talks around what earache is, how to take the temperature, when you should worry, what to do if your child does any of the following. And it also has a green thing, self-care, so what you can do to help yourself. It got the slides you just see, you can see where I got the antibiotic messages from. How long will symptoms last? So it explains that earache, can last between 3 to 7 days. So really helpful to explain that. Prevention, how can you help, what to do. Really great information. What I think is really helpful is this button at the top here, if I can find it. So you can SMS share.
Link, SMS share.
Tick you're not a robot. Put in a mobile number.
Recipient number, UK.
Put in a mobile number and share.
Share.
It's free for you to use. So you put that usually parent or carer's number in, they will get a link to that page and all that information, so they can find that really quickly. So as you can see, I've also clicked the accessibility page there. So on the accessibility tools, we can recite. So people who find English more difficult to read, for whatever reason, can recite it. And we can also look for different languages. So
image, Royal College of Paediatrics and Child Health logo.
It's a huge list of languages, and you can just click a language and the whole page then gets translated. Now, we know people can't always read the language that they converse in, but because of the recite function, so how that works is you actually highlight.
Earache occurs commonly in children and is often associated with a high temperature. It is usually caused by a viral infection.
So as you can see, you could do that.
Your child may.
So as you can see, you could do that in other languages too. So really helpful to show somebody that, and then actually they've got that information to go back to. This is quite a new website, so it isn't in your service specification details because it wasn't up and running, but it was launched on Monday. We thought really helpful to share with you. So I'm going to go back to the slides now. And somebody nod, let me know that they can see that clearly. Or shout out because I can't see anybody. Sobia, can you nod for me? It's you I can see. Fab, thank you. So I think we've covered antimicrobial stewardship and messaging there. Red flags, we've discussed a little bit about red flags and the escalation, how important it is to escalate relating to the urgency of that. So hopefully you feel really confident about your red flags now following the training that you did, and you've got to use your clinical judgment as to what you think's right. So it isn't actually just to the GP, it might be to the out of hours service, it might be to go to urgent treatment centre. There's one in St George's in Middleton, so you can use the NHS service find to find out when it's open. And it might need to be A&E depending on that urgency. So important that you're all, you're familiar with that and follow that if you need to. It doesn't happen often, but we need to get it right when it does. So the other escalation process is for you to refer back to the GP for either a prescription only medicine assessment or and that can be urgent or non-urgent. So if the signs suggest that you feel an antibiotic's needed, or you need further advice, or that there's something you think that you should get a second opinion, you do need to complete the referral from community pharmacy form. Now the form is done by PharmOutcomes. I'm going to go show you how to do that in a bit, so we'll cover that later. But what we suggest you do is, once you've made that referral form, you can print that out from PharmOutcomes, and then you contact the surgery, you make the appointment, you explain the urgency of that to the reception team, and then you can give the patient that referral form, because although the practice do get notified, there is a chance that the practice admin team won't have coded that and added to the patient records when they get to the practice. So by you printing out the referral form, the GP can see what you've done and can have that information to hand. And it might be that the practice actually you can nudge them to go find that referral and send it to the GP, and they actually make an assessment over the phone. That will depend on your practice, but yeah, really important that you probably print that form out and give it to the patient. Again, when referring, don't give any expectation of any specific treatment. We don't want people to go with it. The pharmacist said you'll give me an antibiotic when that might not happen, because that makes it very difficult then, and take the prescriber a lot longer to make their consultation. Referral form we talked about is embedded in PharmOutcomes. Now, what you'll see when I show you PharmOutcomes is the details of the GP referral. We've actually set it out in the SBAR mechanism of communication. So SBAR is stands for Situation, Background, Assessment, Recommendation, and it's a clear and concise mechanism for clinical handover. It's used really commonly across all healthcare. So I know it's used in hospitals, so it's been evidence-based for working, and it really helps you quite quickly give the information that's needed for that clinical handover, so that hopefully when you hand it over, the practice have all the information they need to then manage that patient. So there's two kinds of referrals that go on through PharmOutcomes. There will be when you tick the referral type as being non-urgent non-urgent, it will, when you tick the referral required yes, it will send a referral to the GP saying, actually, you need to see this person, either because they've got red flags or because they've got non-urgent. As I say, you've got to do that over the telephone too, but we have that backup mechanism that goes through PharmOutcomes. What will also happen is, for every single consultation, the GP will get a record of the consultation, so that can go onto the patient's records. That's separate. So they'll get two notifications for a patient that you actually see and make a referral for. They'll get a referral form and they'll get that background information. But all you need to do is complete PharmOutcomes properly, and it all happens like magic. So just a bit of notes on clinical handover. So it's really important that we demonstrate to the practice when we're making a referral, or indeed just making our records, that we make that referral properly and clinically. So earache needs antibiotics, is earache not able to treat in pharmacy, would not be good ways of doing that clinical handover, because it doesn't give the prescriber any information to act on. It just gives your view. And actually, we know where pharmacies have used similar wording on CPCS, that actually this can undermine GPs' acceptance of CPCS, and also the kind of the advice we give. It just doesn't feel, it just leaves them with lots of questions and no answers. So an example of a good referral would be appointment need for patient. They have been assessed, earache duration of 3 days, but it continues despite analgesia, tympanic membranes distinctly yellow and moderately bulging, patient generally unwell. So we kind of know that 3 days kind of criteria has been hit, and it does look like that patient, that 7-year-old, does have an infection. We're not saying that they've got an infection necessarily, and we're not saying they need antibiotics. We're just giving the information we've got on assessment. If you've done the temperature, you should put that in there as well. You know, so yeah, it's just about reporting what you've examined and what your assessment of the situation is, so they've got the information they need. Then they can duplicate that if they want, or they may decide to actually accept that and act on that, and that will be for the GP, because they will take on the responsibility for that, for the onwards management. 3, follow-up. So really important we do the follow-up. As I outlined at the beginning, 2 reasons for this. One is audit, but the more important reason is to make sure that we have managed those patients successfully, and that they are well, or they're certainly well on the way to improvement. That needs to happen between 3 and 5 days after the initial consultation. So we've left that up to you, and that'll be, you know, around when you're busy. If you're not open at the weekends, it gives you that flexibility, but it will need to be between 3 and 5 days. So think about how you're going to remember to do this. So you know, if you've got a pharmacy calendar, it might be wise to put it in there, or put an alert, or there needs to be some way where you remember consistently to phone that patient up. We do expect to take up over the phone, so make sure you do get the correct phone number for somebody. You know, they can do it, they can come to the pharmacy, you can do it verbally in the pharmacy if you want, but yeah, you can certainly do it over the phone. A bit like CPCS, but if you attempt to contact the patient and can't get through, you do need to attempt at least one other contact on a separate occasion. So calling back 5 minutes later doesn't really count. You know, give it a couple of hours and call them back. If after 2 attempts you can't contact the patient, then you do need to still record it, so you get your payment, that you record it as lost to follow-up within the PharmOutcome follow-up module, and that will generate your fee. I'm not actually going to demonstrate the ENT follow-up because it's really simple. You can see nearly all what PharmOutcomes asks you on the screen to the right-hand side. So it's a really quick, you know, how did you follow up? What's the summary of the outcome? You know, so has it been, you know, partial or complete resolution of symptoms that don't need any further action? Did the patient go to an alternative healthcare? So actually we need to ask people, what did you do? Have you been to see somebody else? So yeah, well, I went to the doctors and they told me that it wasn't an infection either, but I've been to the doctors, or I've been to the doctors and I've got an antibiotic. It's a separate kind of response for that. We've put a response in because it might be on question and the patient says, actually, it's got no better and I'm feeling really, really unwell now. And actually that might trigger you to ask them to come back down to do another assessment, because it could be they've actually not got any better and you feel that you need to do another ears and throat assessment on them. Patient admitted to hospital might happen, we've got it in there, or other. And really key as well, asking the patient, if you hadn't have had this assessment with me, what would you have done? So would they have gone to their GP, done nothing, gone to A&E? You know, so we need to kind of get a feel for what people would have done if it hadn't been for the ear, nose and throat service. So payment. Set up payment of £200, which is a one-off payment per contractor, and that will be made when you start delivering the service. There'll also be a £125 backfill allowance available for each pharmacist attending the Advanced Clinical Skills half-day workshop. Pharmacists were given forms at the workshop. If you haven't got a form, email us at info@cpwy.org. And just a reminder, you have to claim for the contractor makes a claim, not the individual pharmacist. The service payments do vary. If it's a walk-in ENT, you'll get £15. If it's a CPCS ENT, you get £10, but don't forget you get your CPCS referral fee too, which means you actually get more money if you get the referral through ENT as a totality. But yes, that's how it's paid. And how that's actually broken down is you will get for a walk-in £10 for the initial ENT assessment and the remaining £5 on follow-up. And for CPCS referral into ENT service, you'll get £5 for the ENT assessment and £5 for the follow-up. So consumables. So you've been provided with some, none, but certainly not all of the consumables you need. And that's because when they were ordered by the Leeds CCG for us, they didn't have the stock required in the NHS supplies. So they have they're sourcing some additional stock. When they have got all the stock available and it's all there, they will then get those ready and they'll get it delivered to the pharmacy. So we know who's got what. So you know, if you've got an otoscope, we know that because, as you know, you had to sign for them. So you know, you will get your missing equipment. You'll get your specular to go on the end of your otoscope. If you've already got your otoscope, and you'll get both if you haven't. You are responsible to fund subsequent purchases of equipment, so this will be the only supply you will get, but you've got plenty, I think, of specular arriving to enable you to do a good number of consultations. We can't give you a date when it's going to arrive with you, but we hope to have the supplies in the next week. And as long as they arrive next week, then it'll be a few days to package it already, get a courier arranged and get the courier to deliver to them. So hopefully within a couple of weeks, but we can't make an assurance, but that is what we're aiming for, because we know that until you've got this, you can't really start the service, because you can't do examinations without disposable specular, because otherwise there would be an infection risk, wouldn't there?
Ruth, can I just add, we expect the stock next Wednesday or Thursday, a day for us to package it, and we are in talks with Leeds City Council, who delivered PPE, that will be delivering the equipment as well.
Brilliant, thank you, Sylvia. So yeah, I know you're working hard on getting it sorted, just we can't be specific yet, can we? So recording the service activity on PharmOutcomes. So as with most things, ideally, when you're doing the consultation, it actually really helps prompt you to do it. So you might find it really helpful to have it open and complete it as you go through. But if that's not possible, do it as soon as you can afterwards, because the quicker it gets put on, the quicker the GP gets the relevant information to the practice and they can code it. Worst case scenario is the day afterwards, but the following working day, but hopefully you can do most of it there and then. I think I've outlined the consultation details I sent to the GP via the notification function of PharmOutcomes. Most GPs have shared and approved which email that goes to. For some, they haven't. So if that's the case, you will actually get a notification that you've got to print it out and then send it via NHS mail, or save it to the computer and send it by NHS mail, which we know is not ideal, but hopefully, and if you have that as an issue, let us know which practice it is, and we will do our best to make sure the practice knows how they can then authorise they do get those referrals straight into the practice NHS mail automatically through PharmOutcomes. So I'm now going to stop share and attempt to show you the PharmOutcomes programme. So bear with me. Sorry, I've got my hay fever slightly flared up this evening, so I'm slightly struggling. I'm just having to log on to PharmOutcomes, and so while I do that, I won't share. Okay, can somebody just let me know? Sophia, I can see you again. Can you let me know that you can see? Brilliant. So this will look slightly different to yours, and that's because I'm previewing it, but as the Community Pharmacy West Yorkshire have written this, made this available for you. So as the people that do that, we don't see it quite the same way, but it should look very, very similar when you log on. So as with many services, you have to put the practitioner names. It's really important that you put that in and you enrol yourself, so it will remember you each time you go on once you've done it the first time. So a lot of these questions you'll have seen in a very similar way for CPCS, so service consent. So you've got to confirm that consent's been given for both sharing the GP practice and for the follow-up. As we covered earlier, if there's no consent given, then actually you can't offer the ENT service. This is just to make sure there's a record that consent has been gained. So when was it provided? Automatically populates with the time and date. So if you're doing it at the time, one less thing to do, but you can go in and amend things as you need to. So if it's been done earlier on today, then you might want to amend it to the time that was done earlier on today. Patient name, it will remember patients. So, you know, if you can put in a patient's, if you've had them before, but if not, you put their name in, their date of birth, their gender, postcode, NHS number. And their contact phone number. So really important we put that in, because you'll need to go back to that when you want to make the follow-up call. The standard question about accessible information, and then GP practice. And so I'm sure you'll all be familiar with this, but you can actually put GP practice in by putting the GP practice name, or you can put a postcode in, and then you can find the GP practice that way. And this bit here that's just popped up, it's now confirming that notifications will go automatically through. So that's where you'll know. But if it doesn't have the green, it will give you the action, and you'll know you need to do something different. Now, before I scroll down, I want to just go through the left-hand side of the screen. And what we've done here is we've got links. So you can click through to the service specification, the service pathway, that's a flowchart that we shared with you earlier, the leaflets that you need there, so treating your infection, you know, common self-care, so the leaflets you might want to share with people, antimicrobial guidance, both local ones, and also the nice ones. So again, it might be worthwhile having a look at this before you go live and just being really familiar with all those links and when you can use them, because you know the Leeds acute otitis media and adults might be really helpful for you to understand what the agreed pathway is. So yeah, really helpful to see that. And what we will do is now, because it's only been in the last 24 hours, we know about that new website I showed you earlier, we will add that at some point too. So you need to say what kind of patient it is. So if it's CPCS, referral, or walk-in. And again, we've put the eligibility there to help you remind us. Let's say this is a walk-in patient. You need to then confirm the eligibility for walk-in. So you need to say which one of these things it is as to why they're eligible. And you'll see for CPCS, it doesn't say that, because if they're CPCS and you think you need to use this service to aid diagnosis, that is the route in, but it's a bit more complicated for walk-in. So let's say that this person's got earache that's lasted longer than 3 days. You need to put the presenting complaint in. So hopefully you'll find most of these standard ones, and we do it this way here because it makes auditing easier. But if there really is another reason, please add as another reason. But we think that most of them should be included in that list. So how long have they had the symptoms? And again, this is just about that safety netting, and make sure from that it's there, that you record that. Have you done anything to help with this condition? So either they haven't, or they might have done, so they could, they've tried analgesia. And any other associated symptoms. So maybe they've got a, we've got this discharge too, I don't know. So you just briefly put in, and you must remember this is you keeping the record, the clinical record of your assessment, what you found and what you did. So it is important that you keep that, because if in a year's time somebody says, how did you manage that patient? We're not going to remember, but you can go back to your PharmOutcome record and you can see, and you'll have all this detail. So this is why it's really important you complete this. And also this information also gets sent across to the practice. So, some of the detail will. So you just bear that in mind. It might not just be you reading, it'll be others. Always really important to remember in any PharmOutcome service, don't put patient details in this box, because that will go through as part of the audit detail. So do make sure that you only put patient details in when it asks you that at the very top. You can see a helpful link here to the nice clinical knowledge summary, so you can click on those if you need to access those. So red flag symptoms, again, there's the reminder about that. So can you confirm that they haven't got red flags? So no, there's no red flag symptom, but if it's yes, then you can record it as yes. So yeah, yes, I've checked the nice clinical knowledge summary and no, there's no red flags. This is the element where we spoke about the fact that if you going to make a referral, which you do need to do, as I say, by telephone to the practice or to the of our services, this is where it triggers off that second notification to say, actually, I'm making a referral. So if you put no, it assumes you're managing that person entirely within the pharmacy. You record the outcome of the consultation. So you gave advice only. Again, you'll see the links here to the target, so you can quite quickly access those if you need to print them out, although personally I'd print a little bit of a batch out and have them to hand. Record the advice that you gave, it's got your safeguarding there, confirm that person's been given that, and anything additional you need to add that, and then your test values. If, however, you think the patient has a symptom that you feel does need to be assessed in general practice, you would then tick that yes, referral is required. Now, that is going to trigger PharmOutcomes to make that referral. So really important, let's say we get that right. So what kind of referral is it? So is it urgent because of red flag symptoms, or is it non-urgent, but actually you want them to assess them quite possibly for a prescription-only medicine antibiotic? So whichever one you use, you get the same thing. So this is going to the S bar. So what is the situation? So you might want to put, I don't know, I won't type it all in because it'll take me ages, but you know, a 7-year-old presenting with unilateral earache. What's the background? So what pertinent information is needed? So you might want to put a bit of information in there around that background. Then onto the assessment. So what do you put in your assessment? So, you know, temperature, anything that if you've done palpating of any kind of lymph nodes, you might say lymph nodes palpated, feel inflamed or enlarged or hard or whatever, whatever you found. If you've done an otoscopic examination, report what you see. So, talk about, you saw the tympanic membrane appears to, burst or have a hole, or there's exudate coming out, or, again, put as much as you can in there, because that records it for you, but also lets the practice know what you've done, and it will help them in their diagnosis. With the recommendation, it may well be, you're asking to have a further examination to confirm diagnosis, or can the patient be assessed for treatment? I'd be really careful at saying they need an antibiotic. I would say assess for treatment, because the patient will see this if you do, as we suggest, print out that record. Again, the outcome, you'd put refer to GP for pub assessment. The device is the same one there, so you tick everything here. So we've told them how to manage it. We gave them antimicrobial stewardship, we gave them a leaflet, or maybe you referred them to electronic resource. Confirm they've been given the advice about safety netting, and then yours will say submit. So that's how you do it. Now, if you want to print out the GP record, you will do that by clicking on here. Now, it probably won't work for me because I haven't got a live program, but for you, you can click on that and it will, let's see if it works. It often, yeah, so you've got the click here to print, and it will then print out the details. It'll copy it across, and you can then, as you can see, it sends a situation background assessment recommendation. That's what the GP will say, and then you can give that to the GP. So I'm going to stop sharing now and go back to the presentation. And with all these PharmOutcome program, your services, when you first start, it seems to take a while, doesn't it? But you'll quite quickly get be able to tick it, and then you'll quite quickly get into your pattern of what you put where. Oops, the daisy, sorry, wrong button. So resources, just a summary for you then. They've got the service specification, really important that you read that. We've got the service pathway and summary, which is kind of a service on the page that we went through. You've got your patient leaflet, you're treating your infection, respiratory tract, or managing your common infection. That'll cover you for things you'll see in the ENT service. There's also some additional training. So as part of the funding we got from NHC&I for support this ENT service, Virtual Outcomes. So Virtual Outcomes is run by an LPC in the Southwest, actually, and they record and make available to pharmacy teams training. Now, we subscribe, so as an LPC we pay for you to have access, but the funding we got was used to actually make 2 20-minute ear, nose and throat learning presentations. They're really good, and actually even if you're the pharmacist doing this, I think you'll find them really helpful. But actually you can share that with the whole team, and it will give your whole team more confidence in what they can deal with with ear, nose and throat. Actually, it'll help them with their red flags too, and just enable you to kind of deliver a better kind of experience for your patients. So as I say, because we fund it for you, it's free of charge. If you click on there, all you need your ODS code. They know the ODS codes for our contractors in West Yorkshire, and you can access it as often as you like. It allows you to allow your teams to do training at a time that suits you. And at the end, they can print out a certificate, which is really helpful if you have your GP/HC inspection, because you can then keep a record of their certificates and you can evidence that you're providing your staff with training. We will come up with more resources as we come across them, and we'll put this onto our website. Yeah, all information about the ear, nose and throat assessment service is on our website. Go to Pharmacy Contracts and Services. You'll see the local services section roughly in the middle, and if you go down, you'll see the ear, nose and throat assessment. So I think that's a bit of a whistle-stop tour through the service, how it works, hopefully a little bit of insight for you. But I think over to the important bit now. I'm going to stop sharing and I'm going to ask for any questions that people have. I've not been looking at chat, so do you want me to have a look at chat to start off with? So there's just comments actually from Sophie and Lisa on there. So there's Lisa just reminding people, closing the CPCS referral will ensure you get paid for your CPCS consultation. Really good point, Lisa, thank you. Serbia reminding us that patients and carers can download the Healthier Together app and actually use it on their phone, so it could be something they can easily find should they need it. And Lisa just confirming the stock is expected by the end of the week. So, Neera, did you have a question, Neera? You'll do you want to come off mute for me?
Yeah, just a quick one. When we do the referral to the GP, for example, how quickly do the surgery respond to the patients? How do we know?
So I think, yeah, so that's the conversation you need to have with the practice, and you please let us know if you find you have issues with getting in an appointment as urgent as you think. But I think it's about you explaining, you know, I've done an ear, nose and throat assessment, this is what I've seen, and I think this patient needs to be seen in the next 24 hours. And indeed what you could do is say, can I book an appointment that you can give, because the patient will still be there, or the carer will still be there, and actually say, oh, you know, they can, you know, and if that's possible, that might be a really good way of doing it. But if you do find you have a struggle getting an appointment, which you shouldn't do, because as part of CPCS there is that referral back process, and we're just duplicating that. But if you do have an issue, let us know, and we'll go through Serbia and her team and let them, you know, make them aware that you're having problems, so hopefully they can give a bit of advice to the practice. But yeah, they should already be willing to do this for CPCS referrals, so this is just should be no different. So hopefully, Neera, you won't get a problem.
Yeah, no, that's a couple of the surgeries are fine. I've got the contacts, I can ring them and organize it. Another one just said to me, well, you make the referral and we'll deal with it.
So Lyra, I don't want to know who it is now, but do you want to bob us an email, and we'll get that onto Serbia, so Serbia can explain to the practice, or Serbia's team can explain to the practice how important it is that actually they need to accept, you know, when we're making a referral, that we've made a clinical judgment call, and you know, we're really clear that with all these things, if the GPs think that it's not appropriate or the timescale wasn't right, they should, not in an accusationary way, but actually they should speak, say, you know, I just wondered why you thought this was the one that needed to be seen within 6 hours, because actually we think it could have waited to the day after. And it's about how we learn, and you know, it's so important. And so I think we need to be receptive to having that kind of feedback from practice, but hope, you know, we also need to encourage the practices to give us that kind of feedback if they think it's necessary, because it's only through talking to each other. It's a bit like CPCS, isn't it? You know, we know a CPCS that we get people referred to us, and we take a look and can't sort this out. But it's about us being able to, you know, speak to the practice, say, look, you know, can I give a bit of feedback? You know, the reason I can't deal with pregnant women with thrush is because of the product licenses. And actually, as they learn and as we listen to each other, things improve, and then they'll hopefully, those kind of referrals both ways will stop, and we'll get to the point where we both know what's appropriate and what's not. We have had a couple of frequently asked questions, so I know that Lisa's been and Alison have been working on those, and so they're going to be on our website. So again, that if there is any questions you come up with afterwards, and for those people that are watching this on playback, please do feel free to email to info@cpwy.org. They'll be passed on to the relevant member of the team. We'll answer them directly, but if it's something we think everybody needs to know, we'll add that to the FAQs on our website so that you all can learn. So, Armadi, do you want to come off mute, and if you've got a question?
Ruth, do we still need to phone the practice as well for the referral, as well as the online?
Yes, absolutely. The online's a backup, so that it goes into the record. But yeah, we need to phone, because how the message from PharmOutcomes goes to an NHS mail address, and how each practice manages that is different. So some might actually, only look at them a couple of times a week, and therefore a referral could be made and missed, and not, or even if it comes through, the person doing its admin and might not realise it's a for action thing rather than just a for note thing. So it's so important that if you think a referral's needed, you need to pick up that phone and speak to the GP practice. If it's out of hours, use the CPCS referral route. So you've got the out of hour numbers, the out of hour GP practice, and explain it to them. And yes, it's so important that we do that, and we make sure we manage those patients. This is about us ensuring we provide a safe service to people. And so we must take that responsibility on, and that's going to be a key part of how we make it a success.
Okay, thanks.
I know, you're welcome. So I want to say thank you to those of you that attended today for being there. Thank you to those that are watching again. If you do have queries, just to reiterate, email to info@cpwy.org. It was really great to see the people I saw at the training event at CPPE. I think there's a lot of enthusiasm for people to start this service. It's something new, but I think, as a pharmacist, it's really, really great that the skills of the community pharmacists are starting to be recognised and used, and I'm sure we can make a really big positive difference to our patients, improving their access and managing more patients within community pharmacy. So thank you for your support in the service, and do take care.